thank you very much for inviting me today. It's lovely to be with you. I feel a little bit outnumbered. Where am I? So I was given this title, Everything an Anaesthetist Should Know About Obstetrics, but was too afraid to ask. I am sure there is already so much obstetric knowledge in this room, acquired through osmosis after hours on labour ward, so I'm sure you've already got loads of obstetric knowledge. What I did as I tried to think about what to cover in this talk was I left an anonymous list in the anaesthetic room of the department where I work. I work with some fantastic obstetric anaesthetists who I respect a lot, and I wanted to know what they really wanted to know. So I have the list with me. Some slightly cheekier questions. Why are some surgeons so slow? That's one of them. How many obstetricians does it take to change a light bulb or do a rotational forceps? And some really, really good questions as well that I'm not sure I can answer, like why do you use CTGs when there's not very much evidence for it? Why do you use a Rouge balloon when it's not physiological? So a collection of different questions. So really this talk is just an accumulation of my own thoughts about the interaction between obstetrics and anaesthetics, as well as trying to cover some of these questions that were on the list. And these are some of the things I'm going to try and cover. I'm just going to try and give you an insight into the mind of the obstetrician. Now, the thing that I love about obstetrics is that it's not black and white. It's all shades of grey, and I think that's what makes it so interesting. But it does mean that we all have different opinions about things, and I guess that probably makes us quite unpredictable as a group of professionals. But I thought I'd talk a little bit about how we decide where to do our deliveries, whether to do a delivery in the room, who to take to theatre. I thought I'd talk a little bit about instrumental delivery, station and position, because that influences, again, where we want to do the delivery. I'm going to talk about what we say and what we really mean. I'm going to talk about some of the limitations of the caesarean categorisation in my mind. Talk about the management of fetal bradycardia. I was going to tell you what the cardinal obstetric sins are that we're all trying not to commit at any given time. I'll be honest with you and tell you what we're really scared about. I'm also going to cover a few of the other questions that were on the list, things like who needs a postnatal Sint infusion, magnesium sulfate, tocolysis, etc. So I'm going to start with talking about instrumental delivery and how we try and decide who we take to theatre and who we aim to deliver in the delivery room. I think for us to attempt an instrumental delivery in the room, we need to be pretty sure that we're going to be able to get the baby out. I've said more than 90%. You need to be fairly confident that you're going to get it out. And if you're not, then this is the time that we start thinking about going to theatre. Analgesia is a factor. Often a woman will have good working analgesia in the room, so that that's very helpful. Sometimes we don't have any analgesia, and that is a factor too, because we need to provide adequate analgesia for instrumental delivery. And we don't want to traumatise the woman. It's worth bearing in mind that going to theatre will actually be more traumatic for some women than having a slightly more painful delivery in the room. So it's a case of gauging how she feels about the delivery and working out whether you can provide adequate analgesia in the room. I think pudendal blocks are a dying art form, unfortunately, but I do think they have a place, and I think we do need to be using them for the instrumentals that we do in the room when people don't have regional analgesia, because I think they help. The position also influences us, the position of the baby. So our ideal, as I'm sure you all know, is direct OA, occiput anterior. If the baby's in an occiput transverse or occiput posterior position, then we're going to have to do a rotational delivery to get the baby delivered, which is a bit more fraught with uncertainty. Some people don't like to do rotational deliveries in the room. I'm open-minded about it as long as the head's low enough. So that's also going to influence your decisions. And then the station, I would say, is probably the most important influencing factor about whether we want to go to theatre or not. I'm going to talk a little bit more about this in a second, but really, when we're talking about station, we're talking about the relation of the leading part of the fetal skull to the mother's ischial spines. And to attempt a delivery in the room, really, the head needs to be below the spines. We're measuring it in centimetres, so +1 centimetre below the spines or +2 for the delivery room. Doing a delivery for a baby that's at spines in the delivery room is quite sporting. You might do it if both your theatres are full and it's a multip and you're fairly sure you're going to be able to get the baby out. But it's those ones where the head's at spines that we're usually wanting to take to theatre. So where on earth are the spines? Obviously I'm talking about different spines to the spines that you're usually looking for. We spend generally about the first 2 years of our obstetric training trying to find the spines and trying to work out where they are. So we're feeling them on either side when we do our VE and then measuring the baby's head in relation to that. So if the baby is above spines, -1, so a centimetre above or 2 centimetres above, then really you shouldn't even be contemplating an instrumental delivery. The thing about all these obstetric rules is there are always circumstances when you might need to break them. So the one case I would say in this case where you might break that rule is maybe with a second twin, for example. But in general, if the head's above spines, you really don't want to be putting an instrument on that baby's head, and you're on medico-legally very shaky ground to do so. If the head's at spines, and again it depends if it's a multip or a primip and what the position is, generally the chances of getting the baby out are about 50-50, and I'd say those are the ones that we often take to theatre for a trial of instrumental. If the head is below the spines, then you really need to be asking yourself the question, do I need to take this to theatre? Does this patient really need to go to theatre? And we have debates about this between the more junior registrars and more senior registrars and the consultants on labour ward. And I think, you know, you start off very cautious and you want to take everyone to theatre because it makes you feel safe. But as you get a better feel for which babies are going to come out, you know, you're able to make better decisions about that, I think. And the other odd thing is that there does seem to be a therapeutic benefit to going to theatre. I always find that the station is at least a centimetre lower by the time the patient is in theatre. I don't know whether it's the jiggling around to get from the bed onto the table or the sitting up for the spinal. I don't know, but there does seem to be a therapeutic benefit. Or whether we have legs in more exaggerated lithotomy perhaps in theatre. But generally you get to theatre and think, actually that's not quite as sporting as I thought it was. The other thing that we often find is that there's often discrepancy between how high or low the midwife says the head is and what we think. I think we're traditionally meaner, both in terms of our assessment of dilatation and our assessment of station than the midwives are. And I think it's because when you're the one who has to put an instrument on the baby's head, I think you're naturally going to be a lot more cautious in calling how low the baby's head is. I'm going to talk a little bit about malposition. As I said before, occiput anterior is ideal. If that's the case, then you can use a ventouse, or you can use Neville Barnes or direct forceps. If the baby's in an occiput posterior position, then you're going to need to turn it round to an occiput anterior position before you can deliver it. And there's three ways you could do that. You could either do a manual rotation, which is basically just flexing the head with your hand and manoeuvring the baby around via 180 degrees. You could do a rotational forceps, or you could do a ventouse delivery. Rotational forceps really divide obstetricians. There's one camp that thinks that they're an instrument of torture and should never be used, and the people who think that, I guess, think that, well, if it's going to turn, I'll be able to turn it manually. And then the camp that do believe in rotational forceps think that there is a subset of babies that won't turn with manual rotation but will turn with forceps. I think I'm somewhere in the middle. And some units don't do rotational forceps at all now. It can be quite regional, I think, in terms of where it is performed. If the baby's in an occiput transverse position, similar range of options. You could use a ventouse, you could use rotational forceps or manual rotation. You need good analgesia to do a rotational delivery, especially if you're going to be doing manual rotation or rotational forceps. And in general, I think that rotational forceps should only really be done in theatre. That's just my opinion. The other thing that I always think about when I'm thinking about this subject is how useful it is to use ventouse in theatre. Personally, I'm a bit anti using ventouse in theatre, although I acknowledge there are some obstetricians who can do anything with a ventouse cup. But once a woman's got a really dense regional block, I think it is really hard for them to push as effectively as perhaps they were back in the delivery room, and that can set you up to fail with a ventouse. Now I'm going to talk a little bit about categorisation of caesarean section. I know there's a few things that you hate hearing, like there's time for a quick spinal. Being married to an anaesthetist, I feel that has influenced my perspective on this a little bit, because my husband hates it when obstetricians tell him what anaesthetic to give. So it's always at the back of my mind when I'm having this conversation. And I think I very rarely ask for a GA. I think it's more helpful for us as obstetricians to try and give you a sense of the timeline that we're working on. So I think it's important in our communication that we tell you why we're taking the patient to theatre. It's amazing how often that information is missed out. When we called it, when we made the decision, and when we're aiming to get the baby out by. So I think saying I called this Cat 1 section 5 minutes ago. I'm quite worried about the CTG. We've got 25 minutes to get the baby out. I think is more useful than trying to tell you what to do in terms of anaesthetic. I feel that quite often with category 1 caesareans, the problem is getting the patient to theatre. And I think then we are quite unfair often in our expectation that you're going to anaesthetise the patient in 5 minutes when we've spent ages, getting the patient there, doing the consent, faffing around. So I think we all need to work together, and we need to work on getting the patient to theatre as soon as possible to give you the most time possible to do the safest anaesthetic that you can. When would I ask for a GA? As I say, I don't do it very often. One of the few cases I think is a bradycardia that's not recovering. I would usually ask the midwife to recheck the fetal heart once we got to theatre, and if it's recovered, then quite often there is time for regional anaesthesia. In that scenario, I think and in lots of scenarios, I think it's really important that we are able to monitor the baby during the sighting of the spinal, but I recognise that is actually a real challenge sometimes, isn't it, especially if the patient has a raised BMI. And again, I think we need to be talking to each other about how we can keep that baby safe during that process. What we don't want to happen is a further 10-minute bradycardia during the spinal going in that we don't even know about. Whether we every 5 minutes have a listen in, or even in cases of extreme obesity, it can be worth putting a fetal scalp electrode on to monitor during the regional analgesia if monitoring is proving difficult. Cord prolapse with fetal compromise, I guess, is a pretty good indication for a GA. I think if the CTG is fine, it's reasonable to aim for a spinal with the patient on the side, but obviously we're going to have to be talking about this and looking at the fetal monitoring. Another time that I'd ask for one is this whole sort of the CTG's making me feel a bit ill scenario, where, and NICE don't have any classification to cover this, but I'm sure you'll know what I mean when I say that the CTG is like more down than up. When you've got those D cells and they're not really recovering, and you just want to get the baby out as quickly as you can in that scenario. And I guess bleeding and a few other medical indications. Just a few thoughts about the categorisation of caesarean section. One thing that I think that the section categorisation ignores is how we communicate the urgency of a trial of instrumental, because it does apply to caesareans. And if you need, so for example, if you've got a prima gravida who suddenly gets a pathological CTG, OP presentation at the spines, you basically need to do a category 1 trial. But, you know, when you say it's a trial, sometimes everybody relaxes and thinks, well, it's not really an emergency. So I do think that's one of the limitations, how we communicate that we need to get the patient around ASAP and assess the feasibility of doing an instrumental delivery. Then, of course, there is the debate about the best anaesthetic for a category 1 caesarean section. We've talked a little bit about GA versus spinal. And some people, traditionally, I guess, have said that you shouldn't do a category 1 caesarean section under an epidural top-up. I've seen people top up an epidural pretty quickly. And also, I feel like some of my colleagues can get an effective spinal working quicker than a GA with the pre-oxygenation. So, you know, I think obviously that has to be up to you guys, but we should all be open-minded about that and not have these, you know, these things that we say like it's a Cat 1 section, therefore it must be this kind of anaesthetic. I feel like there should be a category 1.5. I'll explain the way that we would usually categorise based on CTGs. If the CTG is pathological, our sort of unwritten obstetric rule is that it should be a category 1 caesarean section. If it's suspicious, maybe with some issues with progress, then we'd usually classify it as category 2. If you're quite worried about the CTG but not quite worried enough to call it a Cat 1, but you really want to get the baby out sooner rather than later, that would be my category 1.5. Because sometimes when you ring up theatres and say, I've got a category 2 section, they're like, oh well, we'll just finish our cups of tea, bring the patient round in 20 minutes, you start putting your TEDs on, and you know, there isn't the same urgency. And it's interesting that the RCOG and the NICE advice about categorisation of caesarean section does actually say that if you call a Cat 1 or a Cat 2 section, you should do it as soon as possible, as soon as practically and safely possible. But it also says that we shouldn't be slaves to the time limits, and we shouldn't compromise patient safety to meet the time limits. So the 30 minutes for category 1 caesarean section or 75 minutes for category 2 caesarean section are mentioned, but actually we've got to keep the patient as safe as possible. And I think this is particularly relevant when it comes to patients who are morbidly obese. And I think this is an area where we potentially should have a bit more discussion with patients in the antenatal clinic when we're counselling them about the risks of being morbidly obese and being pregnant. Really, it's just not safe for them to have category 1 caesareans where you have to get the baby out within 30 minutes. We have to prioritise their safety. And I think that's a very sobering thing for a woman to understand, that actually if their baby's in trouble, their weight means that we may not be able to get that baby out as quickly as if they were, you know, if they had a lower BMI. And I don't know whether that could be a motivation, you know, to lose weight after pregnancy. But I do think we need to prioritise safety. And then one of the other questions that I had on the list, which I think is a very good one, and one that's currently close to my heart, is it reasonable that a category 4 or an elective section can turn into a category 3 caesarean section if there are no elective slots available? Well, we are having a big problem with this at the moment at the Jessup Wing. My answer would be no. So this is a category 3 versus a category 3. Yeah, this is a bugbear of mine because I think these women don't get as good a deal as the elective caesarean section patients. They don't have the same experience of pre-op clinic, and they can end up waiting around for a really long time, being starved for a really long time, getting dehydrated before their sections. So no, I don't think so. So that's something that we need to address in our organisation, I guess, of the elective list. I did want to just talk briefly about fetal bradycardia. We have quite a specific timeline in our mind when we're dealing with a fetal bradycardia. And, you know, when we do multidisciplinary skills drills, I guess we all become aware of this, but I wasn't sure whether this is something that anaesthetists have got in their heads at the same time as they're dealing with it. So if a woman on labour ward has a fetal bradycardia, fetal heart drops, the midwife will immediately start taking some sort of conservative measures to try to improve the situation. So they might change the position of the woman, might turn the syntocin on off, check the blood pressure, give some IV fluids. So we're looking for reversible causes, or what the cause of the bradycardia is at this point. At 3 minutes, that's when the midwife is supposed to pull the emergency buzzer. It's quite a long 3 minutes, actually, and I think the emergency buzzer often goes off before 3 minutes. Then everyone piles into the room, and it's important to do a vaginal examination to check the woman isn't suddenly fully, to check that there's not a cord prolapse, to assess whether progress or whether you're going to be doing a section or an instrumental, and then you're going to start talking to the woman about having a caesarean section if it's not recovering. In this scenario, I personally always do verbal consent because I think you can waste a good couple of minutes trying to get a consent form and fill it in. So this all happens in the 3 to 6 minute period. When the emergency buzzer goes off, you would hope that an obstetric crash call would go out as well, which would bring the anaesthetist into the situation. We're all fighting for the attention of the woman at this point. We're trying to get verbal consent for a caesarean section, and the anaesthetist is trying to do an assessment. So it is a very pressured, fraught time. At 6 minutes, that's when we're supposed to move to theatre, and then we're supposed to be in theatre by 9 minutes, and the baby's supposed to be delivered by 15 minutes. So it's a very tight time scale, and that's kind of what's going through our head when we're dealing with a fetal bradycardia. Now, another interesting question is, if the fetal bradycardia is recovered by the time you get to theatre, should you ever go back to the delivery room? And again, different obstetricians will have different views about this. I feel quite uncomfortable about going back to the delivery room because I think if anything subsequently happens and they got to theatre and then they went back to the delivery room, we haven't delivered the baby, I feel like it makes us, again, medico-legally vulnerable. But you do have a bit of time to think if it recovers in theatre. I work on a general rule that if you go to theatre, you should come back with a baby, but not everybody thinks that. So I thought I'd just do a quick straw poll, because one of the questions on the list was, is it ever reasonable to take a patient to theatre without the anaesthetist having seen them beforehand? So I thought we could do a vote, because I don't know the answer to this question. I do have my own opinions about it, of course, but what do you think? Should we say, no, it is never acceptable to move a patient to theatre without anaesthetic review? All those in favour? Okay, or yes, it is occasionally acceptable to move a patient to theatre without an anaesthetic review. Gosh, I'm really surprised. I thought you were all going to vote the other way. Maybe there are a few circumstances, dire circumstances, where you'd have to go to theatre without an anaesthetic review first. But I kind of feel like there's not much point, because if you're not there when we get there, then we can't do anything. So I'm usually happy to wait until the anaesthetist arrives. I guess the difficulty is if the anaesthetist is in another room dealing with something else. And then you're just going to have to communicate well and make decisions between you. But I do think that's a difficult one that prompts a lot of debate and discussion. Another question, which you would think wouldn't have to be asked, but does, is it ever acceptable to move a patient to theatre without an obstetric review? Because that has been done before. So these are the cardinal obstetric sins that we are taught and told that we should never commit. And in some cases, I think it is true, but I think having unbreakable rules and things that we should never do doesn't acknowledge the uncertainty and the variety of clinical exposures that we see. So I've put this list up here just so that you know if any of these things are happening in your theatre, your obstetrician is likely to be feeling pretty stressed out because they're about to get criticised by all of their colleagues for what they're doing. It may still be in the best interests of the patient, but these are some controversial areas. So one of them is doing a caesarean section for a second twin. This is a real sort of losing obstetric face scenario. But I think there are some circumstances where this is the safest thing to do. And actually we have to put the patient's well-being above our own obstetric reputation, don't we, or our desire not to lose face. Doing a caesarean section for a dead baby is often something that is widely disapproved of, and I can understand why. Nobody wants to put a scar on a woman's uterus for a stillborn baby, but actually we have to prioritise the woman at that point rather than prioritising her future pregnancy. So again, I do think there are some circumstances where you do have to do that. This is a terrible thing if it happens. The head's really, really low, you're sure it's going to come out, you do an episiotomy and then it won't come out. That's dreadful. A sequential instrumental. If you end up using more than one instrument, it basically means that you chose the wrong one in the first place, probably. And we know that using more than one instrument increases neonatal morbidity. Again, there are some cases when it has to be done, but it does make us feel uncomfortable and it makes everyone else feel uncomfortable too. And then how many pulls on your instrument of choice? Well, really it should only be 3. I think most people can justify a 4th pull in certain situations. If the head's on the perineum, if you've got past the point of no return, but you are getting onto very medico-legally shaky ground beyond that. And then I also thought I'd tell you about what we're really scared about deep down. I think the biggest thing is a poorly baby, a bad outcome, a baby going to special care who nobody expected to go to special care. And that's horrible for the parents and it makes you feel terrible as well. Something that we all secretly worry about is the failed instrumental in the room. It doesn't happen very often, or it shouldn't happen very often if you're making the correct decisions about where to deliver. But it's pretty stressful for everybody involved. Briefly mention this. The point of no return is difficult to define, but sometimes a baby's head gets so low that you think, really, I'm never going to get this baby out at cesarean, and then you're kind of committed and worry about getting to that stage and not being able to get the baby out. I know you're pretty used to unconscious patients. We really don't like it. And then the classic one, I guess, is not being able to get a baby out at cesarean section after a failed instrumental, after you pull the baby down. I mean, often we try and disimpact the head back up into the pelvis. Sometimes that's less successful than other times. Just a few things to think about if you're in that horrible scenario where the seconds are ticking by very slowly and the obstetrician doesn't seem to be able to get the baby out. What can you do from your end? Get them a step if they haven't got one. A little bit of head down can help sometimes. Sometimes we can get our hand around the presenting part, but the uterus is just contracting so much that we can't get the baby out. So sometimes some uterine relaxation can help. GTN is probably the quickest thing to grab, I guess, or some butylene if you've got it to hand. It's just worth thinking about in advance if you've got a very deeply impacted head section that you're about to start, I think. And one thing that we really appreciate, usually a deathly silence descends on the theatre and everyone is watching you as you try and get the baby out. And if you can keep a bit of a light-hearted chit-chat going with the patient, we really, really, really appreciate it. And then I had a few more questions, just a couple of questions left on this list. What does a pathological CTG actually mean? Well, unfortunately, the breaking news is that CTG classification has changed again. So in 2014, I don't know whether you guys are aware of this or not, but in 2014, pathological and suspicious went, and they became abnormal and non-reassuring. But in 2017, NICE have just declared that they are back. Pathological and suspicious CTGs are back. And they've changed all the classifications, all extremely confusing and very, very unmemorable for us. So it's useful to have lots of crib sheets around on lay board. So what does it really mean? Well, it's either 2 non-reassuring features or 1 abnormal feature. Non-reassuring features are a high baseline rate, reduced variability for 30 to 50 minutes, or variable D cells, and there's lots of different ways of defining the variable D cells, and you have to look at whether there's concerning features associated with them, how long they've been going on for, what percentage of the contractions they're occurring with, or that you can have 1 abnormal feature. So low heart rate, high heart rate of 180 or more, sinusoidal rhythm, reduced variability for more than 50 minutes, or concerning variable decelerations. Another question that I had was, what should the cut-off for severe preeclampsia with protein-creatinine ratio, and when would you decide to give magnesium? So this is just a little summary of when we would decide to give it, and it's not black and white, but this is as black and white as I can make it. This is from the NICE guidance. So we give it to women with severe preeclampsia if birth is planned within 24 hours, and that is the NICE definition of severe preeclampsia. So the proteinuria level itself doesn't actually influence our decisions that much. We're just looking to see whether it's there or not, and it's the level of hypertension that dictates our decisions about whether to give it or not. But also we're using magnesium sulfate for fetal neuroprotection as well, and I'm sure you're familiar with that from a lot of your units. So obviously the management once you get to theatre, if you're giving magnesium sulfate purely for fetal neuroprotection, is different in that you're going to stop it once the baby's delivered. Whereas with preeclampsia, we usually carry it on for 24 hours afterwards. And this is my last question that I was going to cover. Is there a obstetric consensus on who needs a syntocinon infusion after an emergency caesarean section? I'm afraid there isn't. Sorry, I know we all have different opinions about it on different days. I personally don't like to give people drugs that they don't need, so I usually like to wait and see what the uterus is like and then ask for one if I need it, but I appreciate then you've got to run around making it, so maybe that's more annoying for you. Obviously we can predict that some people are more likely to need it than others if they've got risk factors. So I hope that I've covered the questions that my anaesthetic colleagues posed and given you a few insights into the mind of an obstetrician. I was just going to leave you with this, which is one of my favourite poems, and I feel like it was just written about labour ward by Rudyard Kipling. And I guess the last thing I would say is just how important communication is between obstetrics and anaesthetics, because that maximises our ability to provide women and their babies with a good outcome. That's it.
Thank you very much for that. That was very useful talk, I think, and I'm sure there are lots of questions.
I just wanted to say something about the business of taking the patient to theatre without an anaesthetic review. I do think it's fine. In York we have some criteria which is supposed to be met to do that. What really annoys us though is if the patient's in the anaesthetic room and the obstetrician's disappeared. That's if it's that urgent, be there to tell us about it.
Yeah, I absolutely agree. That must be very annoying. But we have, sometimes a scenario when in the next room we've got another patient who needs to go to theatre.
But we can't possibly address that anaesthetic without a proper handover. So that's what
Hi. We've had a current problem in very recent years with patients having it, or babies having rallies, get rushed around, it's all great clarity, you go in there, you stick in the blood, put your spine, you lie them down, and then someone sticks the CCG monitor back on and says, oh, it's okay, it's okay. They go back to the room. Really? Yeah. No. We decided, it happens so often, we decided to still try and have an actual policy for what happens. Yeah. And now we made a decision that, because there's an unofficial board the next thing that happens before it comes out. But the method for this resistance, I just wouldn't have a big problem.
That's really interesting. I mean, I've heard about people taking patients back to theatre, and I have worked in places where that's happened. Generally, it doesn't happen that much where I work. And I think if you put it on and the fetal heart's improved, I think you can all relax a bit and breathe a sigh of relief and think about optimising safety at that point and doing a nice controlled entry rather than a sort of slash and grab section that you would do if the fetal heart was still down. So I would say that it changes the atmosphere and the demeanour of all the staff in the theatre and maybe we can do things a bit more safely, but I would personally still do a section in that scenario. But maybe we just unnecessary sections. fetal bloody. I mean, if you have one on the ward and it recovers, how many fetal bloodies is too many? I usually say it's okay for a patient to have 1 or 2 if they recover quickly. By the 3rd bloody and the 3rd emergency buzzer, I would just take someone to theatre, to be honest.
Okay, so last question.
I don't understand what's the point of obstetrician washing hand before anesthetists and getting it.
I agree with you. We should get out of the way. We should be doing up your gowns and getting your gloves out.
Right, okay. On that happy note, we shall break up for the coffee break, and we'll be back here in about 20 minutes. Thank you.